Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This is the wrap-up of the ACC 2023 meeting in New Orleans. As always, I do the wrap-up together with my good friend and colleague Joost Daemen. And it was quite an interesting meeting with a lot of useful randomized controlled trials that were presented. And maybe we can start with the TRILUMINATE, Joost.
Yes.
Because this was a trailblazing trial in the sense that it was the first randomized controlled study that looked at treatment of tricuspid regurgitation. 350 patients were randomized 1-to-1 to either normal care, which basically is based on a diuretic therapy, or TriClip treatment, so a transcatheter edge-to-edge repair for severe tricuspid regurgitation in patients at very high or high operative risk. And the primary endpoint was a hierarchical composite of mortality, need for tricuspid surgery, hospitalizations, and an improvement in KCCQ. And it's very important to understand the Finkelstein-Schoenfeld methodology there, because you look for the win ratio. So every patient is compared with the other patients in the control arm. So one patient is compared with 125 patients from the control arm. And then you look, is he or she winning? And then you keep counting for every single patient in the treatment arm. So basically, it turns out that for the primary outcome, for the hierarchical outcome, there was a clear win ratio in favor of the treatment with tricuspid, with the TriClip therapy. And this was predominantly, basically only based on an improvement in KCCQ. A lot to say about this trial. I think the sample size was limited, and basically this was an underpowered study to look for real clinical endpoints. But there are some interesting takeaways, and I think the most important one to me is there was no effect on hard clinical endpoints. So as a matter of fact, numerically there were more hospitalizations in the TriClip arm, and there was an improvement in the KCCQ, but the improvement was moderate. There was an increase of the KCCQ score, a mean increase of 12, which is in the moderate range, but not very shocking. And then it was also quite striking that the 6-minute walk test, which is a functional assessment, deteriorated in both groups and was more or less the same in both groups. So the question then arises, is TriClip a good therapy for patients with tricuspid regurgitation? Well, it works in terms of reducing tricuspid regurgitation, and it's safe. But does it change the lifespan of the patients, and does it really add much in terms of functional assessment? That remains the question, because obviously this was an open label study.
I think that is a critical comment. I mean, obviously it's difficult to perform sham controlled trial in these patients, but with a therapy like this in patients that are typically older, frail, in which there's no change in heart, and not even, the more objective clinical endpoints like repeat hospitalizations, etc.
Yeah, well, again, the trial was underpowered for that endpoint, but it's also worth mentioning that only 20% of the screened patients were enrolled in the study. So definitely a heavy selection bias. Absolutely. And it was also unclear, both from the presentation, but also from the trial as published in the New England Journal, how the selection process went on. Because one of the criteria was that the screening committee should determine prior to enrollment of the patient in the study that there was a high likelihood that the TR would improve with at least 2 grades. Well, how do you do that? So I don't know. So that's very obscure to me. So my takeaway is this is definitely a trailblazing study, but it begs for more research and more robust research. There was also a lot of interaction with heart failure docs, and they were not convinced at all. So we really need more data to also support for reimbursement purposes globally.
Alrighty, UK mini mitral.
Yeah, that is also an interesting study. This is more focusing in the surgical arena. A trial from the UK where patients were either with severe mitral regurgitation were either treated with a minimal invasive mitral repair strategy or a conventional open heart surgery with mitral repair surgery. And the principal endpoint, the primary endpoint, was physical functioning at 12 weeks. Yep. Well, the primary endpoint was no different between the two treatment strategies. So the minimal invasive strategy and conventional strategy had the same outcome in terms of physical well-being at 12 weeks. But there were some highlights there. For instance, patients were discharged earlier in the minimal invasive therapy, but at the same time, cross-clamping was longer, procedure time was longer, and the question then, and also the time on cardiopulmonary bypass was also longer in the minimal invasive treatment strategy. So my conclusion is that in this trial that involved surgeons that were very qualified to do the procedures, it did not make a fundamental difference between a minimal invasive and an conventional open heart surgery. And this basically is just a next trial that seems to illustrate how difficult it is to prove a benefit of these so-called minimal invasive surgical techniques. It is really reminiscent, for instance, of the off-pump CABG. That's also very difficult to prove that it's better than conventional open heart surgery with CABG. I think this is a next trial in that series.
Absolutely. COAPT, 5 years. That's also a trial that generated quite some fuzz and discussion, and a little bit already in line with what we expected, right?
Yes. So in the preview, we already highlighted that this would be an interesting study, but from different angles. Again, to memorize, we are talking about more than 600 patients with HFrEF and moderate to severe or severe mitral regurgitation, and then patients were randomized to optimal guideline medical therapy or optimal guideline medical therapy, and on top of that, MitraClip. First generation MitraClip, we already are familiar with the 2-year primary outcomes that MitraClip improved rehospitalizations and mortality. Now a follow-up was extended to 5 years. At 5 years, as expected, a very high mortality. More than 50% in the treatment arm and more than 2/3 of the patients in the control arm had died at 5 years. And the rehospitalization rate was also quite impressive. The annualized hospitalization rate for heart failure was 33% in the MitraClip arm versus more than 50% in the control arm. So very high number of events, so a very sick patient population. I think this trial attests to the fact that heart failure really is a killer and comes with high morbidity and mortality even today. But there are some limitations to this study, and I think an important one is the underuse of contemporary established heart failure therapy. So Entresto was underused, and unfortunately it was more prescribed in the MitraClip arm than in the control arm, and that also may have affected the outcome. And SGLT2 inhibitors were not prescribed in the study. So heart failure docs responded to the presentation, and they said, let's first focus on the golden four of medical therapy for heart failure dogs before we start to think about treating FMR. And also of interest was that the benefits for the MitraClip was already established at 2 years. After 2 years, the outcome was clearly parallel between the treatment arm and the control arm. And that also may have been, could be explained by the fact that almost 50% of the surviving control patients after 2 years crossed over to the clip arm. So they received a clip. Obviously that will affect the outcome out to 5 years. So it is a little bit of a complex interpretation, but at the end of the day, it's quite difficult for a systematic mechanical treatment on top of proven medical therapy to make a real difference. But I think still patients will be referred for FMR treatment, and rightfully so, because you will improve the quality of life of those patients. And probably we're all familiar with compliance to medical therapy in the heart failure setting. That's not very easy, and I think that is where FMR treatment has an important role to play.
Absolutely, I couldn't agree more. To me, two things. At the end, we are talking here about, again, elderly, sicker patients. Entresto trials. The vast majority of Entresto trials did not include patients with severe functional MR. Obviously, these drugs work, but to me, this trial illustrates the potential durability of the treatment with the MitraClip. There were a lot of crossovers in the control arm, but not so much redo procedures in the active treatment arm, right? That was quite rare. The treatment effect remained up to 5 years, and as expected, at the end we all die, right? So what you would expect is at the end that the event curves will get back together after all. But the trial showed the concept of improvement in quality of life as well as mortality benefit at 2 and now even at 5 years. So to me, I think interesting data about a trial that really changed the way we treat these patients.
Yeah.
Evolut, low risk, also longer term follow-up data.
Yes, so we already alluded to the fact that 3 years follow-up data would be presented, and John Forrest did exactly that, also published that in a concomitant JACC paper. More than 1,400 patients had 3 years of follow-up. They were treated at low risk to either TAVI with an Evolut system or surgical aortic valve replacement. Turns out that at 3 years, TAVI really was still winning, and that came as a surprise to me, because if you look at the composite of mortality or disabling stroke, there was almost a 3% absolute reduction in favor of TAVI, and it just missed statistical significance with a p-value of 0.051. So I think this is a very strong signal, and what also was of note, and we already said that could be an interesting part of that study. Do we see any issues with endocarditis, valve thrombosis, or structural valve degeneration? Nothing of the kind. Numbers were very low and were similar for the two treatment arms. As expected, the valve performance after a TAVI was superior to surgery, but there was more paravalvular leak and more pacemakers in the Evolut arm.
Yep, very, very important data in terms of durability, specifically for the Evolut valve. Very reassuring data, actually.
Very reassuring. Obviously, if you really want to have an answer to the durability question,
longer follow-up.
We need the 10-year follow-up that is planned for this study all along.
Good. Revived, also one of the trials that generated a lot of interest actually last year, but now again some new data, or perhaps not so much new data presented at ACC.
Exactly. So the novelty was relatively limited. Basically, the main finding was that viability testing did not add much to the identification of patients who would do better with the PCI strategy, because there wasn't any benefit. What did come out of that sub-analysis was that if there is scar, well, you identify the patients who will get events, but they will get events regardless of the PCI treatment. Again, we have discussed this at length internally and also during prior previews and wrap-ups. I feel that in Revive, not the right persons were enrolled, because a third of the patients were completely asymptomatic, and 2/3 of the patients were in New York Heart Class 1 or 2. So if you compare that to the STITCH trial in STITCH, which became a positive study at 10 years, the follow-up was longer, but also the patients were more symptomatic. And interestingly, also in STITCH, viability testing did not add much to the treatment selection process.
Yeah, I have to admit I was a little bit puzzled by the subgroup, the rationale for the subgroup analysis, as within Revive, patients needed to have evidence of viability testing, or ischemia testing, I should say, up front. So all patients actually should have had a positive non-invasive stress test showing ischemia and signs of viability. So I'm a little bit puzzled on how these results would have changed the primary message. But I think the bottom line of the trial is, as you rightfully mentioned, 2/3 of the patients, no angina. I mean, what does it take? 2 patients per site per year enrolled within the trial. I mean, that illustrates the type of patients that were enrolled.
And again, we don't see those patients in the cath lab. Asymptomatic patients are not sent to our cath lab. And by the way, again, for this particular analysis, the amount of viability that could be seen was not associated with outcome, and that is an important message.
Absolutely.
Okay. Let's move now to the coronary space a little bit further. Deep dive into complex PCI.
Yeah, so a deep dive into complex PCI was a study within the RENOVATE trial. So RENOVATE is another South Korean blockbuster, I can say, presented by Lee and colleagues, who did a randomized controlled large outcome trial, 1,600 patients that underwent complex PCI and were randomized 1-to-1 to either imaging-guided PCI, being either IVUS, in this case 75% IVUS, or OCT, versus angio-guided PCI with a primary endpoint up to 2 at 3 years. of target vessel failure, and the authors were able to conclude yet another positive trial on imaging-guided PCI, reporting a 37% statistically significant reduction in the primary endpoint of target vessel failure at the median of 2.1 years. Interesting trial. Half of the patients had stable angina, as mentioned, 75% IVUS, so most patients had IVUS and not OCT. Some baseline findings, imaging-guided procedures turned out to be approximately 16 minutes longer, so the imaging added some time to the therapy. Although I have to mention that within this trial, pre-procedure imaging was not mandatory, it was just post-PCI imaging that was mandatory. What was also interesting, a very consistent treatment effect in this study population that consisted of complex PCI patients. I think that is important to mention. So patients with CTOs, 20%, in-stent restenosis, long lesions, and so on were enrolled. Also in line with, for instance, optimal, the authors were able to conclude that optimal stenting criteria were reached in approximately half of the patients. Somewhat higher percentage, 66% in OCT versus 56% in IVUS, something that may generate interesting secondary analysis on the trials that have not been yet released on potential differences between IVUS and OCT. And again, also this trial showed a significant impact of stent optimization. Once you did optimization and reached the optimal treatment targets, event rates could be reduced to 6% versus 12% in the angio-guided group, which attests to the fact that simply using imaging by itself doesn't help to improve outcome. You really need to react to it. Yeah. So to me, an interesting trial, again, confirming the superiority of imaging-guided PCI. By the way, in an endpoint that was mainly driven by reduction in mortality, which is quite striking. 53% reduction in cardiovascular death at 2 years. So that I think is a very important finding of this trial that hopefully now will further boost the guideline recommendations on the use of imaging.
Obviously, it becomes more realistic, because I think there is a higher threshold to adopt invasive imaging to guide simple PCI procedures. I think that is that's not going to happen. But in a complex setting, I am a believer, and basically this trial is the predecessor of CHIP IVUS and the IMPROVE trial. Both are randomized controlled trials ongoing both in Europe and in the United States, focusing on IVUS guided versus angio-guided PCI of complex lesions. And for instance, for CHIP IVUS that we're doing here, this trial will wrap up its enrollments by the summertime, and so we hope to be presenting that sometime by the end of next year. All right.
Good. More on
But another trial that also comes from our stable is BIOVASC.
Absolutely. So again, congratulations to you. You were the senior author of the paper. A randomized controlled trial performed in 29 sites in Europe, looking at a potential difference between immediate complete revascularization versus a staged revascularization approach in patients presenting with acute coronary syndrome. So BIOVASC enrolled 1,500 patients, looking for a primary endpoint of at 1 year of any death, MI, repeat revasc or stroke. And looking for the non-inferiority of both modalities that have been widely discussed within the field as well as in the guidelines as of to date, in the absence of a dedicated prospective trial actually attempting to answer the question whether there is any difference between immediate complete versus a staged approach in patients with ACS and multivessel disease. So to me, a few key messages, but I look forward to your comments as well. So to me, immediate complete strategy is safe. The procedure at the end, I mean, an immediate complete revascularization strategy in these patients, which were mostly two vessel disease patients, was on average 61 minutes. So I mean, time is usually not the issue. I think that was one important finding. There was a difference in MI and repeat revascularization favoring the immediate complete arm. So that hints in the direction of potential significant advantages of pursuing a immediate complete revascularization strategy. One important item was that the event curves that at the end were of course non-inferior with event rates of 7.6% versus 9.4% for the primary endpoint. had a numerical difference, but the difference in the events occurred within the first 30 days. That was mainly driven by the fact that a lot of patients in the staged arm actually came back within the 6-week time period for a urgent repeat REVASC or MI. So I think that is something that is of interest, specifically in light of the fact that 2 out of 3 patients within the trial were non-STEMI patients, that in which the COAPT may have been missed during the index PCI. Imaging use was only 7.6%. So, I mean, that warrants again for the increased use of imaging, specifically in non-STEMI patients, I believe. Again, obviously there's a mixture of STEMI and non-STEMI in this patient setting that could be pursued as a sort of some form of critique to this trial. But interestingly, if you look at the heterogeneity plot, there was no difference in the heterogeneity in the treatment effect in STEMIs and non-STEMI. So actually the difference was or let's say the treatment effect was very consistent among both arms. So to me, to conclude, a trial that has actually immediate implications to our current clinical practice, as it really helps us to safely and rightfully perform a ad hoc or immediate complete revascularization in patients with multivessel disease and ACS.
Yeah, so basically I think the trial was well received, and again, because of its practicality. Roberto Diletti presented it on site, and there was a lot of reaction from the community. I think it is important to recognize that not every patient went into this study, right? The more complex the coronary vasculature was, the lower the likelihood that the patient would end up in the trial. That said, 60% of the lesions were considered to be more complex. But we all know that the definitions of lesion complexity can be somewhat liberal. But I think an important comment was, this myocardial infarctions. It is very difficult, as we all know, in an ACS setting to make the diagnosis of a procedure-related myocardial infarction. Yeah. And a lot of the infarct difference between the 2 treatment strategies was an increment in procedural myocardial infarctions in the staged arm. And obviously, in the staged phase, patients no longer have elevated troponins as they enter the trial or as they enter the procedure. And obviously in an ad hoc complete, they are having elevated troponin levels from the get-go. So then it becomes difficult to identify it. That said, the majority of the infarcts were spontaneous infarcts. And also the major difference was driven by unplanned revascularizations in the staged arm. And the reason is that patients per protocol were planned within 4 to 6 weeks for their staged intervention. And things happened in those 4 to 6 weeks. And as we all know, in the setting of an ACS, whether it's a STEMI or a non-STEMI, there is quite, the lesion instability is not only at the culprit level. Absolutely. But also can be in the other lesions. And I think one of the interesting findings that you mentioned is the underuse of invasive imaging. And we already mentioned the RENOVATE trial. Well, ACS might be also a setting where you would want to evaluate non-culprit lesions with invasive imaging, just to make sure that you are treating the culprit, and also to have an idea of the instability of the so-called non-culprits. Because obviously I can imagine that if you would find a thin-capped lesion or a lesion with another recent plaque rupture, that's not a patient that you would want to keep out for another 6 weeks before you bring the patient back in for a staged intervention. So
absolutely.
So definitely very happy and proud with the results of the study and the publication in The Lancet. But more on lipid lowering and plaque stabilization, the Yellow 3 study.
Yeah, Yellow 3, as alluded in the preview, is a prospective observational trial initiated from Mount Sinai in New York to study the effect of evolocumab on coronary plaque characteristics in patients with stable coronary artery disease who underwent multimodality imaging using OCT and NIRS at baseline and 26 weeks. To study LDL lowering and the change in vulnerable plaque characteristics in patients with non-significant lesions, so lesions up to 50%, were screened for high-risk features, and then if so, randomized, or let's say patients were put on evolocumab to study change in vulnerable plaque characteristics in this 26-week time period. So a relatively short time period, but what the authors were able to show is that the incidence of TICFAS, so thin cap fibroateromas, decreased from 43% at baseline to 13% at 26 weeks. So that's, I think, a very important finding now, confirming that the addition of PCSK9 inhibitors to statins in these patients really helps to promote plaque stability, in line with recent data, for instance, from Pacman that already demonstrated the similar findings with alirocumab. But another interesting thing and feature about this trial is that there was also genetic testing, because what the authors found that there were 20% of patients that did actually not show a change in vulnerable plaque characteristics, and 1 out of 4 patients did not show a reduction in lipid core burden index. And the question is, why is that? And obviously we're talking about a relatively expensive therapy here that does work, but also comes at a price. And in this study, there was extensive genetic testing performed, in which the authors may be able to identify certain specific patient profiles that perhaps do not have a huge benefit of these expensive drugs. So with a therapy that is likely applicable to a huge amount of patients, I think this could become something of interest, and something that we might see back in larger future trials, looking at the impact of potential genetic testing.
But definitely overall consistent findings, and basically establishing the fact that with PCSK9 inhibitors you stabilize plaques, and I think that is an important takeaway, and it also seems to help move authorities also to reimburse these kind of treatments at an earlier stage. And the situation in the Netherlands, by the way, is about to change in the forthcoming weeks, so that's a good thing.
Good. More on lipid-lowering therapy, a blockbuster.
Yes, the CLEAR trial. Dr. Nissen presented CLEAR, which was an evaluation of bempedoic acid versus placebo in almost 14,000 patients who had a cardiovascular event or were at very high risk to develop a cardiovascular event. An interesting study, because bempedoic acid basically impacts cholesterol synthesis like statins do, but it is a prodrug that is not metabolized in the muscle. So the issue of myalgias and all that kind of problems should be less common with bempedoic acid. The study had a positive primary outcome with a 1.6% reduction in the primary composite endpoint of cardiovascular mortality, I think stroke, revascularization, and myocardial infarction, which is good news, and the reduction of the cholesterol level was around 22 to 24%. And by doing that, you had an impact basically as expected on the primary composite outcome, which is already in line with what we already know. My takeaway is, okay, most of those patients, they did not, all of the patients by default did not tolerate statin therapy, and the complication rate or the issue of side effects was very low. There was 1% risk of gout, and there was some bile issues, but very limited, and myalgias in only 5%, and no difference between the treatment arm and the control arm. 30% of the patients interrupted their therapy, but also 30% in the placebo arm interrupted their placebo tablets. So basically a very good safety profile. Is this an important add-on to the treatment armamentarium? I'm looking forward to what you're going to say. I think it's, yeah, probably it is. But at the same time, this is definitely not an alternative to statins. Let's make no mistake, because the cholesterol lowering ability of bempedoic acid corresponds to moderate to low intensity statins. Make no mistake, with the high dose statins you can reduce the cholesterol levels with at least 50%, and then with PCSK9 it's another 60% reduction. So those are reductions from another level. But I think it might help and serve patients who really do not want or cannot take statins.
Yeah, I think these final words are critical in my opinion, if you ask my opinion about this trial. So want or can take. This trial illustrates that in patients that do not tolerate a statin, this drug works. It results in a significant reduction of relevant clinical endpoints at 40 months, right? So it's not a short-term effect again. Again, illustrates that any reduction in LDL-C helps in terms of reducing hard endpoints. So I think that is another key takeaway, but it also illustrates the fact that, I mean, look at the patients in these trials. I looked at Fourier, for instance, 75% males. In most other statin trials, 75% males. In this trial, 50% males. Why is that? I mean, I think that has to do with the inter-patient variation in how patients are tolerating drugs, but how they are interpreting the side effects and so on. And we know that female patients have higher rates of intolerance and as well non-adherence. And that said, within this trial, with 1 out of 3 patients discontinuing the drug because of likely presumed side effects or whatsoever in both arms, illustrates that it's not just the tolerability, but it's also the adherence that may have played a role within this trial. 1 out of 3 had a proven discontinuation, but that doesn't say a lot on the patients that actually continued the drug, taking their everyday pill for these 3 to 4 years follow-up, which could mean that the actual treatment effect is perhaps even slightly underestimated. But that said, I think it's an important trial that adds another agent to our armamentarium that works in terms of reducing endpoints in patients that at least say they cannot tolerate their statins. Yeah. But yeah, so interesting trial. Good.
And then lastly.
Last but not least, a small trial, but I think an interesting one. That was data presented on MK-0616, which is the work name for a new oral PCSK9 inhibitor. So this is a drug that recently demonstrated to be effective, but was now studied in a phase 2b trial in which 381 patients were randomized to 4 doses of MK-0616 versus placebo on top of statins, looked at LDL lowering at 8 weeks, which appeared to be able to be reduced 61% as compared to placebo, 52% up to 52% reduction in ApoB in the highest dosages of this agent. No differences in adverse events, so truly safe agent. And with the highest dose, you could reach your LDL-C goals in 91% of the patients. So again, pros and cons. So this is an oral agent, perhaps somewhat more affordable than the injectables, but again an oral agent. So it works on top of statins, yet I think as shown also in clear outcomes, I mean there's also an advantage, right, of bringing patients twice a year to the hospital to get their inclisiran shot. You know that they have it, you know that they will have the benefit. So I think there's pros and cons to all kinds of therapies, but again, a promising agent that is likely to be studied further in larger phase 3 outcome trials.
Yeah, let's hope that this matures a little bit further, and that we at one point will end up with a randomized controlled study to oral PCSK9 inhibitors and then parenteral PCSK9 inhibitors, because this issue of therapy compliance should not be underestimated, and I think that might be one of the absolute benefits of parenteral PCSK9 inhibitors. Yeah. Okay, with that, we are coming to the end of the highlights of ACC 2023. I think it was quite a good meeting.
Absolutely.
Interesting stuff. So now full steam ahead to the next big trial that we're going to cover. That probably will be EuroPCR in spring. Thank you very much for staying with us for this wrap up. We hope to see you soon. All the best.
Thank you. Bye-bye.